Good afternoon and welcome to today's Grand Rounds. Please remember to fill out the attendance records, and also please, if you would, fill out the program evaluations and give us any ideas that you might have in regards to future topics or future speakers. Today, it's my pleasure to introduce Dr. Jeremy Fields. Dr. Fields is board certified in both internal medicine and gastroenterology. He's a member of the Department of Gastroenterology here at Mary Greeley at McFarland Clinic. He went to medical school at the University of Michigan, then did his postgraduate training at the University of Iowa. He did his medicine residency and GI fellowship there, and he's here today to update us with GI clinical pearls and new GI services. And please join me in welcoming Dr. Fields.
All right, thanks. People hear me? Yeah? All right. This is informal, so feel free to jump in at any time. There'll be time for questions at the end, I hope. So I'm here to talk about the new services that we have and a few clinical pearls. I don't have any disclosures. So we have a whole bunch of new toys here at the hospital in the GI lab. Radiofrequency ablation. We have the capability to do endoscopic mucosal resection now, single balloon enteroscopy. I do gastric variceal glue injection in case of emergencies, and an endoscopic ultrasound. So the first two things I'm going to be talking about have to do with the treatment of Barrett's esophagus, dysplastic Barrett's esophagus. Dr. Barrett was a thoracic surgeon, and this is normal esophagus, and this down here is Barrett's. So why bother with Barrett's esophagus? Well, esophageal adenocarcinoma doesn't have an extremely high incidence, but it's on the rise. Relative incidence compared to 1975. A few other cancers are increasing, but nothing's increasing as quickly as esophageal adenocarcinoma. And the 5-year survival is less than 20%. There are now fairly low invasive ways to treat this before it turns into cancer, or even if people have early cancer. Here's a little schematic of normal esophagus and then Barrett's esophagus, low-grade dysplasia, progressing to high-grade dysplasia, and then cancer. So patients who have no dysplasia have less than 0.5% chance of progressing to cancer over the course of a year. If you have low-grade dysplasia, it's just less than 2%. If patients have high-grade dysplasia in their Barrett's, they have a 7 to 10% chance per year of progression to invasive cancer. So that's pretty high. You know, somebody's 60 years old and they have high-grade dysplasia, wait 10 years, you know, they're going to have cancer. We had a number of endoscopic interventions available before the current technologies, lasers and plasma coagulation, cryotherapy. They were not well tolerated at all. They were really reserved for patients who couldn't tolerate an esophagectomy. So here's one of our new toys. This is called radiofrequency ablation. It looks like a little circuit. One of the tools is on a balloon, and another one is about the size of a postage stamp and is on the end of you attach it to the end of the scope. And you either, if somebody has a large area of Barrett's esophagus, you put one of these balloons down, blow it up so that this is in contact with the esophagus all the way around, and you deliver a controlled burn. And the hope is that normal lining will grow back over that area that you burned. If there are small areas, you can treat it with the smaller one. It's a very sort of a controlled burn. It burns very superficially, and the rate of complications from this is extremely low. So here's a little picture of what it looks like before. Somebody has a long, this is looking down the distal esophagus. It looks like they have probably about 6 or 7 centimeters of Barrett's esophagus. Here's that balloon. You can sort of see through the top of it, it's clear, but that circuit board looking thing is in contact all the way around. You burn it. This is what it looks like just after you burn it. You go back in a few months later and it's normal. In reality, it usually takes a little bit of touch-up work with that smaller device to get it to look this good. So it usually takes 2 sessions or so. We get rid of all the Barrett's esophagus more than 85% of the time. We get rid of all of the dysplastic Barrett's more than 95% of the time. And this is usually in 2 sessions. Patients have some pain afterwards. It's usually not terrible. There's plenty of patients who never go get the pain medicine that I prescribe for them. But I tell people to expect a little bit of pain for 2 days, especially if we burn a large area. We have them on a clear liquid diet for 1 day. I mean, this is outpatient. They just go home. They drink liquids that day. They eat normally the next day. They have some medications that they have to take, but it's very well tolerated. The complication rate is supposedly about 4% of causing a stricture, a scarred esophagus that's narrow that you have to stretch. In practice, it seems that that's quite a bit smaller than 4%. A slightly more invasive but still endoscopic treatment for dysplastic Barrett's esophagus is endoscopic mucosal resection. So this is cutting out bumps basically in Barrett's. It can also be used for early esophageal cancer. It's still much less invasive than esophagectomy. It's still outpatient. Patients actually tolerate it a little bit better. Patients rarely have pain after this. And there's a variety of techniques for this, but there's essentially a little clear cap that goes on the end of the scope that has rubber bands on it. You suck up the tissue, flip a rubber band over it and make a little polyp, and then using a snare and cautery, you cut it off. And you can cut out a very large area by doing multiple areas adjacent to each other. There's a bleeding rate of about 10%, but this is most of the bleeding that happens during the procedure. We control it. It's rare to have patients come back with problems of bleeding. We can certainly cause scarring and esophageal stricturing, so that requires dilation if we cut out a very large area. And again, afterwards, patients rarely have pain. Again, we have them on a clear liquid diet for a day and some medications, but this is outpatient. Both of these require patients to come back in 3 months until we're sure that it's gone, so it's frequent endoscopies. Patients maybe expect 4 endoscopies in a year. And then after we do this, we're not sure what the incidence is of recurrence, and so we still bring patients back maybe every couple of years to make sure that they're not developing Barrett's again. If patients have cancer that's confined to the mucosa, we can often cut it out with a scope, and we get very good, we can get margins and be sure that we got it all. And frequently patients who have early cancer won't require anything more than this outpatient procedure. It's also used to stage early cancers. If you think you might be able to cut it out, you try, and you might find out afterwards that you didn't get it all on the margins and that they'll require chemoradiation and surgery. All right. Anybody have any questions about those things? All right. So moving on from Barrett's, we also have the capability to do deep enteroscopy now. With an upper endoscopy and colonoscopy, you can see the first few centimeters of the small intestine and the last few centimeters of the small intestine, and there's about 6 meters in between that you can't see. Previously, we would use a pediatric colonoscope to push down into the small intestine, maybe 60 centimeters or so. And now with this long flexible scope with an overtube that has a balloon on it, we're able to inch down about halfway through the small intestine. There are other this is what we have here. There are other technologies. There's a double balloon enteroscope, and also this spiral thing that augers you down. That's a little bit brutal. The main reason that we use this for a lot of reasons, most of them are most of them will come from GI clinic, I guess. But the main reasons that we use them are for bleeding. Patients with angioectasias in the small bowel, frequently elderly patients with heart failure who have bleeding requiring transfusion. We'll put them through this and get down as far as we can and burn these spots. Patients with polyposis syndromes often who develop polyps in the small intestine, we use this for as well. And there's a bunch of other things for Crohn's and strictures and stuff that we use it for. as well as for patients who've had Roux-en-Y gastric bypass or some other Roux-en-Y anatomy to try and get back to the excluded stomach. So it's this long, thin, flexible tube, and here's a schematic of how it works. It has this plastic sheath on the outside of it, and that sheath has a balloon on the end that we can inflate and deflate. And generally, if you didn't have this, the more you pushed in, once you got to a certain point, it would just buckle, basically. The scope loops instead of pushing in further, but you're able to fix the bowel with this and pleat the bowel. So you blow up the balloon. To fix the bowel, you advance the scope, and then you anchor the end of the scope. Deflate the balloon, slide the sheath in, blow the balloon up again, and then you pull back and pleat the bowel, and then you do it again. And doing that, we're able to sort of work like an inchworm quite a ways down under the small bowel. It's a long procedure. It takes an hour and a half. It's a lot of sedation. We generally only do it if we have a good reason to, if we find bleeding on a capsule endoscopy or something. We're not doing this for iron deficiency anemia, and we didn't see anything on the other scopes. It's a lot to put somebody through, and often these patients are elderly and ill. One other thing I guess that's new is we have the capability to glue gastric varices. It's super glue that we use, basically. We used to buy it at ACE. It was this is actually why super glue was developed. It was developed for military applications, trauma and bleeding. So that's why the little toy you're trying to glue back together, the glue will dry much quicker on your fingers than it does on the toy. Once it touches tissue, it polymerizes immediately. So we basically take a long needle, stick it into the varix, and inject glue. And there's risks of bleeding and embolus with this, as you can imagine. It's very effective. It's very high risk. There are some places that are doing this prophylactically for patients with large varices. I just do it here in the emergency setting because we don't have the interventional radiology backup in house in case something goes wrong. But it's much better. There have been 2 randomized controlled trials done by the same group. They showed a mortality benefit for gluing if patients had bled from these large gastric varices. In 2-year follow-up, the number needed to treat was 5, so we only had to glue 5 people to save 1. And then even in patients who haven't bled, who have these very large gastric varices, they have the same risk of bleeding, really. The number needed to treat is 5. There's not much else prophylactic that we do in medicine with, I don't know, that looks that good in terms of mortality. It's risky. The mortality of doing the procedure is about 1 in 200. It's not FDA approved. And it's probably will never be FDA approved because there's not enough call for it, and the glue's already available. If we inject, there are some downsides. If we inject too quickly, the glue doesn't have time to polymerize, and it goes downstream. Some of it always goes downstream. And even though we're injecting veins, cirrhotics have intrapulmonary shunts, and so they get arterial emboli. I think all of them do. So anyway, it's risky. Moving on to some more practical tools. Endoscopic ultrasound is new here. This is a technique where there's a miniaturized ultrasound probe on the end of a scope, and we can use it to look at structures sort of in the wall of the GI tract or near the GI tract. So, in a schematic, here, these yellow things, the pancreas, we frequently do this for pancreatic lesions or pancreatic cysts, either looking through the stomach or the first part of the small intestine. There's not actually this big of a gap. You can see quite a bit of the liver as well. There's 2 different types of scopes that view differently. One of them is a radial scope. It has a field of view that's all the way around the scope. If the scope is up like this, the plane of view is this. And this is really just used for viewing. The other scope, sorry. All right, so here's a picture of what it looks like. Here's the scope, and then the view around it. This is a linear scope, and this is what we use to do biopsies with. And this, the plane is here, and when we biopsy, we can watch what we're biopsying. So here is the view, here's the needle coming out, and here's the tip of the needle. You can even see the bevel doing a fine needle aspiration. So we are able to do fine needle aspirations as well as core biopsies. We can go up to a 19 gauge core biopsy, which isn't that big, the pathologist will tell you, but. So this is just a little schematic showing what I see when I'm doing this. This is the scope in the stomach, looking up at the liver, and there's a metastatic lesion. There's a cyst in the liver and a hemangioma. So just by the ultrasound characteristics, you can frequently tell what things are, and sometimes we do need to aspirate as well. We have Doppler capability in the scopes as well. Anyway, so this is that's what I see. The indications for this, again, some of this is very specific to GI. We stage esophageal and rectal cancers. We're able to look at the primary tumors as well as for lymph node involvement and biopsy lymph nodes. Sub-epithelial lesions that we see on endoscopy or that are found on scans. Pancreatic masses and pancreatic cysts, pancreatic cysts are difficult to know what to do with. Evaluating the biliary tree for cancer as well as stones, and then I'm frequently called for, I saw this on a CT scan, can you get a piece of it? Lymphadenopathy or liver masses. It can be used for celiac plexus block for patients with pancreatic cancer and pain. We can inject some alcohol basically and destroy the nerves there so that they're not in so much pain. It can also be used for a few other therapeutic things like pseudocyst drainage, draining it into the stomach or the duodenum. And this is what I'm looking for when I'm doing this. The layers on the endoscopic ultrasound correlate with histologic layers to try and figure out how invasive things are. The layers are bright and dark, and it depends on sort of where you are in the GI tract. But it does actually, so here's a radial scope. This is artifact. And then these are reverberations from the scope. And then this is where the GI tract starts. And you can see a bright layer, a dark layer, a bright layer, a dark layer, a bright layer. So if there's a tumor, you can figure out how deep it goes. So in terms of T-staging cancers, this is a schematic for esophageal cancer. This would be a T1, and there are some subclassifications that are difficult on endoscopic ultrasound to sort out, but T2 is into the muscular layer, into the muscularis propria. T3 is through the muscle layer. T4 is if it invades something else. And we can also see lymph nodes. So this is a schematic, and this is what it looks like on endoscopic ultrasound. This is what it looks like on the end viewing scope. There's a little mass here, and they can see that it's T1, and then we can just cut that out. Here's a stage 2 cancer. Anyway, you get the idea. T3, here you can actually see it fairly well. This is the paraesophageal fat, is this bright stuff, and you see the mass going into that. But it's not going into the aorta. And here's another mass. This whole thing is the mass, and it invades the bronchus as well as the pulmonary artery. And we also look at the liver while we're in there. We see maybe a third of the liver or so, but we can biopsy liver metastasis as well, upstaging cancers. We use it for rectal cancer as well. And we can evaluate for sphincter invasion and lymph nodes and other important things for the surgeon and the oncologist. We frequently use this for sub-epithelial tumors. What that means is that the lining over it is normal, but there's clearly something here. So we can look at it and also get core biopsies or fine needle aspirations. And that's important. Some of these have a malignant potential. This is a gastrointestinal stromal tumor. It has a malignant potential that depends on the size and where it's located in the GI tract. This is a lipoma. It's totally benign. You don't have to worry about it. This is a leiomyoma. It's big enough. We take it out. And you can see what layer these things arise from. Frequently, you can see this arise from this dark muscle layer here. That's anyway. Here are some gastric varices. You don't want to biopsy those. Make the patient bleed to death. Yeah. And there's a whole bunch of other fun things. Lymphomas, metastatic lesions to the GI tract, carcinoids. One of the very difficult clinical problems we often run into in GI is what to do with pancreatic cysts. Endoscopic ultrasound can be helpful in risk stratifying patients. Many of these are benign. A few are malignant. Many have some malignant potential. You think of them like colon polyps, but they're a lot more difficult to get out. We find a lesion that has a few % chance of turning into a malignancy, but in order to get it out, you need a Whipple. So it's hard to know what the right thing to do is in these. Some of them have a characteristic appearance on ultrasound. We don't have to worry about them anymore. Pseudocysts. This is a mucinous cystic neoplasm. Here is a needle in it, getting some of the cyst content out. These have a malignant potential. Here's a malignant one. Here's one with a nodule that's concerning, so there are some characteristics of them that help us know how dangerous they are. This is a serous cystadenoma. This is totally benign. You don't have to worry about it. They don't need surveillance. They don't need any follow-up scans. These often will have a characteristic appearance on ultrasound. And then IPMN usually has a characteristic appearance on ultrasound as well. And these have a malignant potential depending on the size and where they're located. We often aspirate them, and we're able to send them for chemical studies, as well as now there's some genetic tests that can be done on this fluid. And if we do biopsy the pancreas, there's a 1 to 2% chance of causing pancreatitis. We often use this to evaluate pancreatic masses, adenocarcinoma, neuroendocrine tumors. We can biopsy them and stage them, evaluate for vascular involvement. And then this celiac plexus neurolysis for patients with, generally with pancreatic cancer and refractory pain. We inject alcohol and marcaine around the celiac plexus to kill the nerves and improve the pain. It has side effects, though, most notably hypotension. EUS for biliary stones, it's at least as good as MRCP, and looking for common bile duct stones is probably a little bit better. It's more invasive. Patients need sedation. An hour ago, I was doing one of these on a patient who had a pacemaker, so couldn't get an MRCP. She had stones, so she needs an ERCP, despite being 90. So you can see shadowing stones in the common bile duct. And you can see gallbladder stones as well. In terms of the risks, they're about the same as a regular endoscopy. It's very safe. But there's a small risk of infection if we biopsy something cystic. And again, if we biopsy the pancreas, the 2% risk of pancreatitis, that's by far the highest risk. I mean, there's much less than 1% chance we cause patients a problem with an endoscopy in general. So in summary, the new tools we have, this radiofrequency ablation is for dysplastic Barrett's. They have chest pain for a couple days. It's very well tolerated. Requires frequent endoscopies. This mucosal resection for early cancer or bumps that we see in Barrett's esophagus has a higher risk of bleeding, but again, very well tolerated. Requires surveillance endoscopies. And this deep enteroscopy, it's long and tedious and messy, and we generally try and do it for a good reason. It's most often done for bleeding seen on a capsule endoscopy. The endoscopic ultrasound is most often used for staging cancers or evaluating incidentalomas or pancreatic cysts, and also for obtaining biopsies of things found on scans. Moving on to another new service that we had that's currently on hold is fecal transplant. See Dr. Arbulu up there? It's a very safe, effective treatment for refractory C. diff colitis. They had this in place before I came. We have prepared diluted frozen stool from a donor that's been screened for every infectious disease known to man. It's ready to go. You can say, I want a fecal transplant. They thaw it out and give it to the patient via enema. But the FDA recently put a stop to basically the safe and effective therapy. They put up a huge barrier to care for patients who need it. Any physician performing this now needs investigational new drug approval and IRB. This was first used over 50 years ago. There's multiple randomized controlled trials. If you look on Up to Date, it's recommended. The recommendation is 1B, which means strongly recommended, and there's randomized controlled trials. Anyway, and it's not a drug that I could fathom it's nothing that the FDA could possibly approve, I don't think. There's hundreds of species of colonic bacteria we transplant that we can't culture sort of in the absence of all the other ones. So we don't even know what we're giving people in the end. We just know it's safe and effective. And of course, maybe we could call it probiotic slurry or something and give it, because the FDA has decided not to regulate the probiotic industry at all. But we're actively working on getting our IND and IRB. Dr. Bulu is anyway, so thank you. All right, moving on to a few clinical pearls. Regarding anemia, not all anemia is GI blood loss, of course. We see a lot of anemia in GI clinic that's not iron deficient, or that's anemia of chronic disease. So check iron studies before you send them to GI. And the other thing we frequently see is the hemocult's not for a stool obtained by rectal exam. Nobody has checked the sensitivity or specificity of stool obtained by rectal exam on hemocult for anything. Especially in the setting of patients on anticoagulation, they'll often have blood from the rectal exam, a trauma from that. And another thing, if somebody's having blood, we all believe you, or melena, we all believe you. You don't need to send it for hemocult and charge them $100 or something. In regards to constipation, at least 80% of the time we find no contributing factor for constipation that's idiopathic. A couple things to check, just a basic metabolic panel, a thyroid. The first thing to try is fiber. Citracel is generally better tolerated in my experience, and that's, what is it? Some kind of methyl cellulose. Better tolerated than psyllium or metamucil. It tends to give people a little bit more gas. You start one capsule at night, and they can take 2 at night if they need it. If they're still having problems, feel free to send them over. Please check a SITS marker study, which is just a capsule that has these little markers in it, and then an X-ray 5 days later, a KUB 5 days later. Usually takes at least 5 days to get into GI clinic anyway, and then we have that to go on to help us figure out if it's slow transit constipation or what. Colonoscopy is not helpful in evaluating constipation. If somebody's obstipated or obstructed or something like that, yeah, but just constipation, it's not. The most common precipitating medications are narcotics and calcium channel blockers. Relistor is available now in patients on chronic narcotics who are constipated, who are, that's refractory. It's a shot every other day of methyl naltrexone. So it's Narcan with a methyl group on it, so it doesn't cross the blood-brain barrier. And you can get that as an outpatient. It's only FDA approved for palliative cancer patients, but I think so are the chronic narcotics that everybody's on. For enemas, don't get creative. If somebody needs an enema, just use water or fleets. Don't use soap. There have been lots of bad things that have happened to patients who've gotten soap. It's not a good place for soap. And molasses is just a mess. Just, yeah. In terms of dietary things, prunes work great. They now call themselves the Dried Plum Association. You know, they've done trials, and prunes work. Figs have more of this stuff in them than prunes do. If you like figs and you don't like prunes, caffeine works too. We are getting our anal rectal manometry machine up and running again. So the new constipation guidelines recommend that everybody gets an anal probe to figure out if they have dysenergic defecation or not. Yeah. All right. Moving on. Hepatitis C. This is a really bright spot in GI right now. We have a lot of there's probably 10 new drugs that are going to be out in the next year and a half. We call it sustained viral response instead of cure for some reason, but the rates are up with these new direct-acting antivirals. It's sort of like HIV meds. We have protease inhibitors now. We're going to have all sorts of other kinds of drugs like those HIV drugs soon. So we have 2 protease inhibitors now for genotype 1 patients. All these, there are multiple new drugs, multiple studies that all look just stunning. Cure rates approaching 100% in patients who failed prior treatment. And soon we'll have interferon-free regimens. Treatment durations will be 3 months instead of 12 months. We'll be able to treat patients with significant psychiatric problems who aren't able to tolerate interferon. So it's exciting. This winter we'll have at least two more new drugs. Basically nobody's starting treatment for hepatitis C right now. There's very, very few exceptions because these new drugs will be out soon and will be much better tolerated. So again, it doesn't matter if they failed prior treatment. We're waiting for these new drugs to come out to treat people. Feel free to send them over in the meantime if you want them evaluated, and we can contact them when appropriate regimen's available to get going on it. A genotype is important to check because it matters in terms of all these treatment regimens. And make sure they don't, it's helpful for us to know if they have cirrhosis or not. So if they had an ultrasound and a CBC, that would be helpful. I've had a couple of patients sent over who supposedly had hepatitis C. They had a positive antibody. I said, okay, could you please check the genotype? And they checked the genotype, and they can't check the genotype because they don't have hepatitis C anymore. But they still sent them over. Anyway, so confirm that they actually have it. The antibody, especially young women, they, not a really high rate, but they have a real rate of clearance of hepatitis C. The new screening guidelines for hepatitis C, anybody born between 45 and 65, or if they had any other usual risk factors. And the reason that the U.S. Preventive Service Task Force recommended this is now we have drugs and we can treat them. So screen people, I don't know, it'll probably be one of these check boxes that you have to do now. Clinical burros about diarrhea. Remember, you don't have to work up every acute diarrhea. I think most of us don't, but some people get $1,000 worth of tests done for acute diarrhea. If it's severe, they're elderly or pregnant or they're volume depleted, or you think they may have C. diff or something like that, go ahead. But if they just have diarrhea for a day and a half, tell them to come back in a couple days if it's still going on. If it's chronic, please check their medications. Almost everybody I've seen in clinic has been tried off their metformin, but a number of patients are left on their oral magnesium, which is the same thing as taking milk and magnesia. So, the usual stuff, culture of C. diff. A 48-hour fecal fat is really helpful, especially if they've had long-standing chronic diarrhea, to evaluate for pancreatic insufficiency. And then in terms of celiac serologies, there's a celiac panel that checks a whole bunch of stuff. The only things you need are a TTG IgA and a total serum IgA to make sure they're not IgA deficient. There's some sort of weird glitch in Epic where it doesn't show up in results reviewed, and you have to look at it under the lab tab. Go ahead and try to fix it. If you look at up to date in the evaluation of chronic diarrhea, it talks about getting fecal electrolytes. That's impossible to do it as an outpatient as far as I'm concerned. If the stool sits out on the counter for an hour, all these bacteria in there lyse, the electrolytes all change. It's hard enough to do as an inpatient and get the very fresh liquid stool to the lab in time. So don't bother, it'll probably be wrong. You know, if you send it off, you'll get something back, but it won't be helpful. And you know, other tests that depend on the history. Feel free to refer, you know, patients with chronic diarrhea. My colleagues asked me to mention this. Patients with chronic abdominal pain, especially women, please screen them for depression, and if it's negative, screen them again. We start a lot of antidepressants in GI clinic, a lot. And then in terms of colon cancer screening guidelines, there are 10 different active guidelines that have been reviewed in the last 5 years that are slightly different. I recommend a colonoscopy when the patient turns 50 for average risk patients, and if negative, another one in 10 years. One very frequent thing that comes up is family history, and this is based on the ACG guidelines. So if a first-degree relative had colon cancer, or if they had an advanced polyp, meaning it was an adenoma greater than 1 centimeter, or it had high-grade dysplasia in it, or villus elements, and they were less than 60, you treat that polyp the same way as a cancer. You figure if they didn't get that out soon, it would have been a cancer. So if a first-degree relative had cancer or an advanced sort of a polyp before age 60, you start at 40 and go every 5 years. Likewise, if 2 first-degree relatives had that at any age, then you start at 40 and every 5 years. If grandma had cancer, it doesn't matter, you know, and nobody else did, average risk. If mom had cancer at 65, average risk. We do a lot of extra colonoscopies on patients whose second cousin had a little polyp or something like that. All right, yep, if mom had precancerous polyps, you're supposed to screen as an average risk unless you know for sure that was an advanced polyp. I don't know, patients who required a hemicolectomy for a polyp or something like that, that probably counts. Some societies recommend screening African Americans at 45 years old. Others recommend starting screening at 50. I follow the ACG. And then another important thing is when to stop screening. So when life expectancy is less than 10 years. The risk of colonoscopy goes up as you get older. Thinner colons, a lot more diverticuli, don't tolerate the sedation as well. So in general, you stop at 75 years old, never above 85 years old. You know, if they're Scandinavian and from Story City and all their parents live to be 110, you know, you can go to 85 if they're healthy. But yeah. Never above 85 and you know, usually 75. Thanks.
Thank you, Jeremy. For people with chronic GERD, 10 years or more, when should we refer for EGD for Barrett's esophagus?
Right, yeah, so those guidelines, I forget who it was, if it was the U.S. Preventive Service Task Force. Anyway, somebody said, we don't know about Barrett's screening. There's no great data that you really need to do it, so we're not going to recommend routine screening anymore for anybody. So patients who have a family history of esophageal cancer, who are white, who are male, who are obese, who've had chronic reflux, those are the patients who are at risk for esophageal adenocarcinoma. So in practice now, if they've had chronic reflux, you have a white guy with chronic reflux who's overweight and he's coming for his colonoscopy at 50, do an EGD at the same time. Save him a trip, and the sedation, and you know, the day after work and everything like that, and screen once and never screen again if they don't have Barrett's. Other patients, I don't have any, many of the studies say, well, if you have multiple risk factors, so I don't know if that means 2 or if that means 4 or what. And in reality, if somebody's overweight and white and has had reflux for a long time, it's probably worthwhile doing the EGD when they get their screening colonoscopy at 50.
Just wanted to give a brief update on the status of that fecal transplant in our institution upon request of Dr. Fields. So we started doing that roughly, I want to say, a year ago. You've been here a year, right? So roughly a year ago. Not long ago, we looked at our rate of success, and it was 80%. That's way better than Flagyl or vancomycin PO for C. diff, so it's consistent with what the literature shows. The reason for failures were usually glitches in the protocol, like somebody gave antibiotics to these people and therefore kind of messing up the transplant because you're not supposed to give antibiotics. But, I mean, excellent rate of cure. What happened is that I got an email from the Infectious Diseases Society of America in early May saying, hey, by the way, FDA is now going to regulate your poop. And apparently that actually has been going on for a few months, and we just learned about that. And it's so, I mean, it is so effective as Dr. Fields has presented, and it's, there's such a great push for using it that there's been initiatives to overcome that barrier. And just hopefully right after this meeting, I'm meeting with a gentleman who is the founder of an NGO that is exclusively dedicated to overcome administrative barriers for fecal transplant. So, I mean, it's that big. So stay tuned. I mean, we may resume this soon, just depending on filling paperwork and stuff. But it's a treatment that sounds a little bit gruesome, scary, but I echo Dr. Fields that it's really, really something we want to get going again.
And they had done, Dr. Abrulu and the rest of the GI division and the lab had really done a lot of work to get this done and made so that, you know, we could do it quickly and easily for patients. And so anyway, it was very convenient. Where I did my fellowship, I got to screen a family member with 1 million questions and then collect their fresh poop and mix it up myself and then inject it into their family member. And this was great. But hopefully this will be back up and running soon.
Excuse me. Here, catch.
I understand that Iowa is a hotbed of whipworm therapy for Crohn's. So where's the status of that? Back to Dr. Abrulu and
so whipworm for Crohn's and ulcerative colitis and refractory asthma. It's been shown to be pretty effective. This is another one of those things that the FDA will never approve. It's effective, I think like 20% of the pigs in Iowa have it or something like that, and they won't approve it because they're worried, oh, your poop could somehow get in the water supply or something like that, and somebody else could get this. Anyway, it doesn't seem to make much sense, but again, they're not going to approve giving an organism to somebody, so I wish they wouldn't regulate it. It's safe and effective. There's Dr. Nisley does some complementary alternative stuff. She's an internist at the U. We'd send patients over to her. She'd find it somewhere on the internet forum or something like that. It's still effective, and now they're working on making some. There's a couple docs working on the molecular mechanism so they can make in some sort of antibody that costs $50,000 a year to give to people. Because the FDA will approve that, Any more questions? All right. Thank you, guys.